All right, great. Well, we are at the top of the hour, and I am very glad you could join us today for a very interesting talk. I have the pleasure of introducing Dr. Carol Geary and Dr. Al Fisher to discuss UNMC's participation in the PREVENTABLE trial, which seeks to test whether the use of statin medications in individuals over the age of 75 can prevent heart attack and stroke or prevent the development of dementia. Dr. Geary will be speaking first. She's a nurse informaticist in the Department of Pathology and UNMC's principal investigator for PCORNet. Dr. Fisher is a professor in the division chief of Geriatrics, Gerontology, and Palliative Medicine in the department. So without further ado, I will hand it off to Dr. Geary.
Good afternoon. I'm getting my screen up. Are you seeing my screen now, Jared?
Yes.
Perfect. So first, thank you, and I'm excited to be talking with you this afternoon. I am Carol Geary, and you can see Dr. Fisher has joined us, and we are here to talk about pragmatic recruitment for clinical trials and our experience here at UNMC. And I will start with more of the didactic side of things, and then Dr. Fisher will get more specific and more actionable, I imagine, in his talk about his experience. So I want to begin, assuming my slides will advance. There we go. I want to begin by acknowledging the Crane leadership team. I am one of three leads. Scott Campbell and Jim Campbell are absolutely necessary to everything that I'm describing today. And we have an entire team that helps us to ensure that things happen and happen as they should. So our objectives today are to first talk about key elements of pragmatic recruitment, and I'll start with talking about what is a pragmatic trial and what is pragmatic recruitment. I'll talk a bit about the UNMC infrastructure, and then Dr. Fisher will share his experience with PCORNet and with PREVENTABLE in specific. So what is pragmatic research? So pragmatic research is built upon the learning health system model, which means that we take the work that we do every day, we take the experiences that we have, and we inform our practice going forward. And so pragmatic research builds on this with the intent of informing decision makers rather than making grand statements or background, or and use the term background, that's not wrong, rather than elucidating a biological or social mechanism. So we're looking at this is better than that, and when is this better than that. Secondly, we look at making the population of the study very close to, or as close as possible to, true clinical practice. So these aren't controlled trials in the most formal sense. They are as close to real world as is possible. And then we look to streamline procedures, including data collection, to allow for a very large N at a much smaller cost than a traditional study would have. Now I'm going to use the Adaptable to illustrate some of these. Adaptable was the first pragmatic trial that I was aware of at UNMC, and it was the first PCORNet trial. And I'll talk a bit more about PCORNet in a bit. So Adaptable was looked at the best dose of aspirin for secondary prevention of cardiovascular events. There was a separate study looking at the best dose of aspirin for primary prevention. So this was very focused on secondary. They looked at a very diverse population, and they describe it as minimal eligibility criteria. I don't think minimal is actually the right word, but it looked to make it a real population, a meaningful population, but not a tightly controlled population. So did they have known atherosclerotic cardiovascular disease? And we used both the problem list and the diagnosis list to support that. An adult, and this used age 18, rather than 19. Safety concerns. Do they have an allergy to aspirin? Access to the internet is something that we can't know. They thought we could, but we can't know from the EHR. But we can know if they have current anticoagulant or other medications, pregnancy and nursing. And then they gave a list of, I don't know, about 10 increased risk factors of increased cardiovascular events. And those were things like age over 65. And so the vast majority of this was knowable through the electronic health record. And the pragmatic operations that we used in Adaptable were actually quite variable from one institution to another. But recruitment was initially intended to be 100% low touch. At UNMC, we stayed low touch. Other institutions used high touch methods, and I'll go into more detail on that in just a bit. They used not only electronic consent, but electronic randomization and communication of the dose that the patient would be taking. They also informed the patient to go buy their own aspirin. So there was not centralized delivery of medication. And then the data collection came in two ways. One was an repeated online surveys that were pushed to the patient centrally. And so our study coordinator had no work to do there. And then PCORNet common data model queries, which means that every year or so they would say, we're ready to get the data, and we would centrally go in and pull all of the data from routine visits or any visits that happened at UNMC or at Nebraska Medicine. We would pull that data and centrally manage it. So there was no collection of data by study coordinators directly from the patients or from the charts. So PCORNet and CRANE are both structured electronic health record data. And this slide is complicated, but I want to use it to kind of walk through the steps. So the first step is we have EPIC here. And so we have a clinical data warehouse that we can pull that data from and into. We have additional administrative data, and then we have some external data. We update the death index, we have cancer registry data, and several other things at this point. And we take that data from EPIC, we organize it, we standardize it, and we check it for quality. And all of this is important because we are using secondary data. These data were collected for clinical purposes, and we are now taking them and making them usable for a second purpose. So CRANE is our local environment. The common data model, the PCORNet common data model is a subset of CRANE that is interoperable with and structurally identical to all the other PCORNet sites. So there are roughly 40 PCORNet sites across the US that all use this same common data model and therefore can use the same computable phenotype, the same computerized inclusion and exclusion criteria to identify patients. So this is from one of the Adaptable papers, and it describes both the approach that we at UNMC took for Adaptable, and we have a very similar approach to Preventable. So this on the left side describes the remote patient recruitment, which is low touch and what we used here at UNMC. And then on the right side of the screen, the in-clinic patient recruitment is the high touch approach that we did not use here, but lots of sites did use. So in the center of each screen, you see the computable phenotype applied to EHRs. So basically that is the black and white, so there is no room for discretion. It is yes or no, in or out. Inclusion and exclusion criteria that were used to apply to the whole of our data mart and identify patients that should be eligible to participate in the study. And so for adaptable, that was they had an atherosclerotic cardiovascular diagnosis, they were adults, and so on. And so when we apply this computable phenotype, we get typically large numbers of patients. So for adaptable, we got about 30,000. For preventable, Al can tell me if I'm wrong, and that tell me if I'm wrong, it was somewhere around 3,000 is the number that's in my head, but I could be completely wrong. For studies of rare diseases, it may be 10 or 100, depending on the on who we are looking for and how many of them there are. We take that list, and then our team organizes them, because we don't want to send out 30,000 notices at once, because we wouldn't be able to handle the responses back, even if it were minimal. And we organize when and how we're going to reach out to patients. In both preventable and in adaptable, we found that reaching out around a visit made it much more likely that folks would respond to us. So we communicate with them. Our office sends out letters, either our office or the PI's office sends out letters. And then the VCR office and the CRC have a very tight approach to how we communicate with patients electronically. And so the VCR's office and the CRC coordinate for emails and MyChart messages. And so we send those out, and then based on experience, we wait a certain amount of time, and then we make a phone call to follow up and ask, did you get this communication? Would you be interested in having a conversation about the study? Now, for adaptable, at that point, we would say, wonderful, you want to enroll? Here's the link is in your email. How can, please go ahead and enroll, and the process is done. For preventable, because there is prescription involved that requires additional coordination, feedback, evaluation, we then connect to the study coordinator, who has another conversation, and the evaluation of the patient's participation continues. Now, this process sounds, I think it sounds pretty simple. It is not. It is the coordination work that goes on is significant, and ensuring that we are meeting all of our requirements and ensuring that we are honorable in the way we are approaching patients requires interaction with the PCORNet team, with the study team, and with the VCR and CRC offices. And I've been delighted to say that interaction has been very smooth and very positive. But I also need to share that the oversight of this and the evaluation of this is not minimal. While these typically fall under a central IRB, local requirements like the UNMC 3 contact limit remains in place, and we adhere to that. This requires that we have ethical access to the patient population, and that is a discussion that at the beginning of the study, and I think Al will talk more about this, requires conversation with both clinical entities and the IRB. And there are both UNMC and Nebraska medicine protocols for patient contact for research. for specific to phone conversations, specific to mail, and specific to MyChart. And each of these have to be acknowledged and adhered to as well. So that's my high-level discussion of pragmatic recruitment. And I will now turn it over to Al to share his experience with Preventable.
All right, hopefully everybody can see my screen now. So I'm gonna kind of focus a little bit more on the why would somebody as a faculty member be interested in participating in one of these studies as a PI. And so I'm Al Fisher. I'm a professor of medicine and chief of the division of Geriatrics, Gerontology, and Palliative Medicine at UNMC. So I've gotten involved in a couple of studies through PCORNet, which is the program that Carol has told us about, and kind of, way I think about these and how they're a little different from other clinical studies you might be thinking about. Often these are ones that they are really looking for large patient populations. And this is either that because the type of participant that they're looking for is fairly rare among our patient population, meaning they have a rare illness or they have kind of unique characteristics. You may just need to sift through a large number of patients to be able to find these. Or it's that you're looking at a research question where you need to have a large number of individuals in the study to be able to answer it with a well-powered clinical protocol. The questions that they're looking to answer are often pragmatic and often are really real-life practice focused, and that's something that is definitely the case with Preventable. It's really one where it's a study looking at statins in folks over the age of 75, and the types of patients we're enrolling are certainly representative of the patients that I see in my clinic every day. There's also the data collection. A lot of it is happening, automated via the EMR. And so, for example, we've sent data on patients that we've enrolled in Preventable, and other than getting an I2B2 automated email, I frankly know little about what's being collected and what's being transmitted on, and really when it's happening even. The other part with these studies is that you're often just a small part of a much larger study. So Preventable, there's probably somewhere upwards of 100 sites at this point, and we're just one of that 100 sites around the country. So it's really more of a teamwork type project than us being kind of the lead person that everybody's focusing on. Through PCORNet, I've gotten involved with 2 studies. So one is Preventable, which is that study of statins in the folks over the age of 75. And interestingly, it looks at not only does it prevent cardiovascular outcomes, but also it looks at, does it prevent dementia, given there's a kind of overlap between dementia risk factors and risk factors for cardiovascular disease. And it also looks at disability as an outcome. So it's certainly very real world applicable, and something I can see myself taking back into the clinic once we have answers from the study. I also, through Preventable, was invited to then participate in the PCOG 90 study, which is one that's still at the submission and funding stage. So I was involved in the initial submission, where I was a project co-investigator for one of the cores. And I was also a site PI for our UNMC Nebraska medicine site. We were scored 3 points away from the pay line, which, on one hand, it was disappointing, but at the same time, it was pretty exciting because it's like, boy, that's going to be easy to move the needle and get that funded on the resubmission. And so I think there's a lot of enthusiasm among the investigators to get this revised and resubmitted. And this is going to be a study looking to find folks who are over the age of 90 who do not have dementia, and then going to study this population at a molecular, social, and physical health level to really try to understand what are protective factors that may help people prevent dementia as they get older. So certainly, again, something really real world and something that my patients would be very excited about learning about. So what are pluses to doing these types of studies? And some of these things have been really a lot of fun to do. And so often you work with a team of established investigators. And so for me, as somebody who primarily did bench research most of my career, this was really an opportunity for me to explore a different type of research than I had really done. And, be able to work with folks who have really long, extensive track records in their areas, that if I emailed them out of the blue and said, hey, do you want to do a clinic, put in a grant submission with me, probably wouldn't get a reply from these individuals. But as you're working as part of the team, then they're very excited to have you as one of the sites they need to help with the recruitment. And then as you get more experience and become known within that population, it then becomes easier to then start to move into lower level roles. And then you can kind of move up as time goes on. There's also a single IRB with most of these studies, which certainly for somebody who's never submitted an IRB before, certainly reduced the stress level in this to a large extent. Also, these studies, since they have these really experienced investigators and folks that are often in really high-powered institutions that are involved with them, the study design is pretty sophisticated and pretty detailed. And so it's one where you can certainly learn about what it's like to participate in clinical research in a environment where you're really getting a chance to see, these are the things that it takes to run a well-run and a well-organized study. Additionally, like the Preventable study runs out of Duke, and also has support from Wake Forest, and you really realize just like, they have some pretty extensive teams that they engage. So for example, it's like our patient enrollment's all done via the web, and these things really look slick and professional, which is something that's really well beyond my ability to easily do something like this. And then finally, often these are things that you can get involved with at the level where they've already been funded, or it may be one that you're kind of involved in helping with the application. And certainly because you've got this, they're addressing important questions, you're dealing with a team of established investigators, the chances that you're going to get funded and be successful are certainly higher than if you're trying to do something like this on your own. An additional thing that was something that didn't really jump out at me at the beginning, but something I've come to appreciate a lot during the study is the use of a computable phenotype. And Carol described this in a great way. I often think about this as it kind of inverts the relationship. So our clinic, often gets contacted by other groups on campus to help with recruiting patients from our clinic into their study. They will kind of tell us about what the inclusion and exclusion criteria, and then the challenge is you're in clinic and you're trying to say like, oh, would Mr. Jones be a good person to refer to this particular study? And the challenge is you're trying to like see somebody in real time in clinic, think about those inclusion and exclusion criteria, stay on schedule, supervise your resident or medical student. And so it's kind of a tough thing to do. Whereas, so, that's kind of one where that patient relationship then leads to referral to the study. Instead, here, the computer does a lot of this work and basically finds the patients for you. And then as a result, you're actually contacting them more about, do you want to enroll in a study? And not necessarily having much of a relationship with them before you enroll them. The other thing that's nice about the computable phenotype is it really allows you to recruit across Nebraska medicine. And there are the ethical access issues that we'll get to in a couple of slides that people have brought up. But, for Preventable, for example, these individuals that we're enrolling have to not have cognitive impairment, not have had a heart attack, not have had a stroke, not be ADL dependent at enrollment, and often that's not necessarily the population of a geriatrics clinic. We often have folks that have good amount of cognitive impairment, a good deal of functional dependency, and so it's hard to like necessarily get the number of patients we need just from our clinic. Instead, often these are folks that live in primary care practices because they're 85, but they're actually pretty darn healthy and don't really have a lot of contact with the medical system. And so we needed to be able to tap into these primary care practices to find these patients. It also, while the computer does a lot of the work, you do need to kind of go in and make sure that the computer did things right, which is actually pretty good at this point. But then also there are things that the computer may not be looking for, like they just recently got diagnosed with metastatic pancreatic cancer, and probably something we're enrolling in a 5-year study isn't a good idea at this point. But these are things that you can easily pick up as a clinician when you go and look through the chart at that point. And then I think the thing that's really been helpful about this is the fact that you're not tied to individual clinicians. We'll see how many patients we've approached in the coming slides. And if I was dependent upon folks giving me leads on all of those, I would be in big trouble at this point. And the embarrassing part of this also is our screens have actually pulled up patients that I've seen in clinic who are in my patient panel, and folks that I've seen multiple times. And it was one where, even though I'm like the PI of the study, I'm most invested in trying to find people for the study. When I saw him in clinic, it totally slipped my mind that this person would have been a perfect candidate for the study. And then the computer found them for me. And I kind of had the embarrassing thing of like, oh yeah, I know that person really well. I saw him like 2 weeks ago in clinic. Of course, they're a perfect candidate for this study. How does this benefit you as an individual faculty member? One is it's really a great way to build your track record in clinical research. So if you're somebody who hasn't done a lot of this and is interested in getting involved, the challenge is that often when a new study is asking you to potentially be involved, they're going to say, what's your track record? What kind of studies have you recruited for? And if you don't have much if you have kind of a limited track record, you may not be as attractive to recruit as a site because they're kind of worried about, are you going to be successful? Are you going to be able to pull this off? And the nice thing is with having the backup of the PCORNet team really helps you kind of get that initial kind of foot in the door, and then you're able to kind of build your track record so that with subsequent studies, you then become increasingly attractive as a person to work with. There's the single IRB that I've discussed, which certainly cuts down on the amount of work that you need to do. Great way to learn about clinical research in a structured environment with established investigators. And so this has certainly been a lot of fun to do. It's also been a way of building connections with other investigators. So it's one where, I now have developed connections with the investigators at other sites because you're kind of working with them on your budget. You're working with them on helping to read and revise parts of the application, for example. You're meeting with them after it's funded to talk about what's going well and not well with patient recruitment. And so for me, for example, I recently was promoted to professor, and one of the people that I had as one of my letter writers is actually somebody that oversees our hub for Preventable. It's somebody that I've known through the field, is another division chief as well. But I felt like I had a better relationship with him as a result of participating in the Preventable study. And so I felt more comfortable with suggesting him as a letter writer. And he was, don't know what he wrote, but it obviously, if it was bad, it wasn't so bad that they stopped my promotion. And then there's also the potential for publications, if you meet the metrics for recruitment and other things that are expected from you. I also thought about when I was agreeing to do this from a division chief perspective. And so for those of you that might be in leadership roles, kind of thinking about, why would you want to do something like this or greenlight another faculty member doing it? And for us as a division, I really thought about it as it's a good way for us to get a foothold in clinical research. When I came here, our geriatrics division was certainly well respected for education and clinical care. Wasn't really involved in the clinical studies in the geriatrics field. And I saw this as a way for us to kind of break into that field and start to develop a track record so we become attractive to future studies in the field. The PCORNet studies also can be really helpful for folks who are generalists or study common diseases. if you work in an area where you take care of a very exotic cancer, for example, inevitably, because often the treatment for that isn't really clear, and it's so hard to get individuals that may have that cancer because it just is a rare one, that you're likely going to get drawn into clinical studies kind of whether you like it or not. But if as a generalist, it's often a lot harder to get involved in research studies because so many of these things happen in subspecialty clinics. And so PCORNet really was a way for us to kind of break into this. Additionally, in geriatrics, there's very little industry-sponsored research. We have $0 of industry-sponsored research right now. And this is the third division of geriatrics I've been at, and I think probably our grand total is somewhere close to $0 of industry-sponsored research. And so PCORNet was really a great way for us to be able to get into research without having industry as a potential helper for that. And then it was also something that I discovered during this process was it's a way to offer access to research for patients. So a lot of the patients I call for preventable are like, are you sure you want me in a study? Don't you know how old I am? And, so these are folks that are often excluded from clinical studies. And this has been something that has allowed them to get access to. And for some of them, that's actually been really meaningful to them and something that they are proud of their involvement in this. What are downsides to getting involved with these? One of the big ones is really you need to review that budget. So preventable was one where the initial budget that the preventable investigators offered was a little on the measly side and didn't really cover our costs. It has gotten better, and kind of the growth of the number of sites probably reflects the budget being better. Fortunately, our division had research funds from the foundation that we were able to tap into to allow us to get started. But if you're in another division, it's something that you may have to have a discussion, with your division chief or your department chair, or if it's one where you already have a clinical research enterprise, and this is just kind of adding an additional study that kind of takes up some of the slack time in your existing team, it may be easier to make it go even with a more modest budget. Along those lines, the budget that we get for preventable isn't able to pay for full-time staff like a study coordinator for us. And so fortunately, our division has been able to pick up the other part of it to make it happen. But it's certainly one where I could imagine if like the Peacock-Nani study gets funded, and maybe if I get involved in another study, that it would become really easy at that point to support a full-time person without any supplemental help. The other thing is that, while the PCORNet studies are often billed as being kind of low touch in terms of faculty effort, yeah, in a way that's kind of true because you're not having to do invasive procedures on them. But if it does involve like calling patients or needing to review charts, that kind of effort can add up over time. And I think I do spend a fair amount of time on the study, and the amount of support we get doesn't always kind of fully compensate us for that. But it is something you need to be mindful of. And then probably the final downside is that you often have little relationship with the participants, and that may be a factor in why we have to do so many touches to get people into the preventable study. There are two of my primary care patients that are enrolled in the study, and those were folks that, it is, interesting that, of the enrolled patients, probably my patient panel is overrepresentative relative to the number of folks we've approached across the institution, and probably that relationship I have with those patients, made them more likely to say yes than somebody who goes to a Grand Island clinic, for example, and has never heard of me or my division. So how are we doing with preventable? So this is the slide they always show at every preventable Zoom call that we have. It's kind of the score sheet. So we're currently sitting at around number 17 nationally, which, one hand you're like, well, 17 out of 100 is pretty darn good. And then also when I look at it, it's like, the folks that we're competing against are some pretty big research powerhouses like Yale, Vanderbilt, Duke University, University of Chicago. And there are folks behind us that are like Johns Hopkins, some of the Mayo clinics, the VA in Los Angeles. And so we're certainly holding our own for the fact that this was kind of our first time doing this, and yet though, or at least my first time doing that, and yet though we're actually doing pretty well nationally. The other fun part is the group that's always right behind me is the University of Texas at San Antonio. I used to be there, and they have a GREC, they have a Pepper Center, which is like hardcore geriatric research infrastructure, and yet though I'm kind of like Wile E. Coyote or I guess the Roadrunner, and actually just staying one step ahead of them, which has been kind of a fun thing during this process too. So this is kind of getting at why you need to have the computable phenotype, and really why you need the bigger infrastructure to be successful. So currently we've reached out to about 2,600 patients at least once. And as you can see from that, folks decline to do it. Folks are ineligible as we start to evaluate them more, and we're able to reach them via a combination of emails, MyChart messages, and also either letters or postcards that go out to those patients. And then kind of from that, you can see that you need to have a fair number of patients contacted and a fair number of touches to be able to get just one patient into your study. And so this is one where if it was all on me to do it, we would be certainly far behind where we are right now. And so you can see that we about a little over 3% of the folks that we contact end up enrolling in the study. And then that leads to us to having about 4 folks a month that we're enrolling. And importantly, we have to evaluate about 31 patients to be able to get one enrolled person. And it takes about 54 touches between a combination of the emails, calls, and other things to be able to get that one person enrolled. Why is this so inefficient? Part of it is just the patient population we're trying to get, folks over the age of 75, and don't have a coronary artery disease, don't take a statin, not a big patient population. So certainly the computer really accelerates this process. Additionally, we're dealing with folks that are over the age of 75. A lot of them have been suggested to take a statin in the past, more for primary prevention because they need it, and because they weren't that amenable to take it in the past. Yeah, what a surprise. They're not as excited about taking a statin now when we talk to them about the study. But we actually have been successful with some of those folks. And then there have been some folks that have been concerned about just being in research. And so those are all kind of, valid barriers to enrolling folks in studies. So what did we learn during this process? And these are kind of tips that if you are interested in doing these in the future, certainly I'm happy to engage with you at that point to give you some suggestions and share the things that we've learned in more detail. One was that you really need to engage with your IRB, and I have to say our IRB has been really very willing to meet with us and to talk through these issues and try to come with solutions as opposed to kind of digging their heels in. Importantly, while these have a single IRB that's centrally done, our local policies can conflict with that. So one of them was the ethical access issue. So initially the IRB was like, you can't, you're a geriatrics doctor. You can contact people in HICSA who are, patients of your practice, but you can't contact folks out in Grand Island, for example. And so as a result, we had to talk to them and say, this study isn't really going to work if we're limited to just using our geriatrics clinic. We don't have enough potentially eligible patients in our practice alone. And so in working with them, we were able to get an ethical access waiver to expand beyond the geriatrics clinic. And that can take a couple of different flavors. I think part of it was the IRB, understood that the computable phenotype was kind of the way we needed to go to get there. They did ask us to initially get some permissions from other clinics to access their patients. And the clinic medical directors that I'll talk about in the next slide were really wonderful and helpful in terms of wanting to help us be successful. The other thing that our IRB wanted was they actually wanted me to meet with every patient that we were thinking of enrolling in clinic to then go over consent with them. Even though the central IRB was fine with my study coordinator consenting them and enrolling them in a study where they're going to get a medication. And so this was, going to be a real barrier because of the fact that, these are individuals that are seen throughout 13 different primary care clinics, and very few of those primary care clinics are anywhere close to where I work on campus. And so I could have spent all day basically driving around trying to meet patients in clinic to go over the study. And particularly with Grand Island, where it's like a 3-hour drive each way, that certainly wouldn't have been at all feasible. So they were willing to allow me to switch, where now my study coordinator does the initial consent, and then I just need to call them, to call the individuals to confirm that and answer any questions they have. And that certainly sped up the process dramatically and made this much more feasible than it would have been otherwise. You also want to make sure that the sites you're going to be using your computable phenotype on know about your project. For us, this got super explicit for us because while we were putting in our IRB application, that was when COVID was first hitting, and UNMC put in the requirement that you had to get explicit permission from each of the clinics that you were going to utilize to be able to do clinical research at their site. And so it really forced us to make connections with them. And if I had to do it over again and there had been no COVID, I certainly would have, like if I was going to do study number next, I certainly would reach out to those clinic medical directors, right off the bat to let them know about it. And so the way I did this, and it wasn't a very involved process. I attended, there's a primary care PCMH patient-centered medical home meeting that happens every month. And I was able to present at the clinical medical directors meeting and answer questions from that larger group, and then ask them for permission. And they were able to send that back to me via email. Some of the later sites that we added, like Grand Island, I actually gave a presentation via Zoom at their clinic staff meeting. And so to make them aware of the study and to get their permission. The thing I found during this is that the vast majority of the clinical medical directors are very excited about participating, wanting us to be successful. We're excited about having this as something that get offered to their patients. Particularly Grand Island was really excited about this because it provides, access to clinical research. Why come to our clinic in Grand Island? Well, because you can potentially participate in clinical research by being a patient with us. So it was a kind of something that helped them be successful and helped us be successful too. The other thing we found is that a lot of our subjects, we started asking them about, do you want to be in preventable? Well, they're kind of thinking about it. And part of that thinking about it process is contacting their primary care doctor to get their primary care doctor's opinion. And so if your primary care doctor has no idea that there's this clinical study that is drawing from their clinic, they get completely blindsided by this, and it's kind of a source of frustration for them, and they don't feel like they can help the patient. Whereas instead they were familiar with it, and then they're able to, to kind of talk through, what their thoughts about enrolling in the study are, and we're able to talk about, how this, that this is a clinical research project, and kind of how they were selected for it. And so that, I think, ended up making them advocates for us and helping us with this process. Other things we learned is the ProCoreNet team at UNMC can actually run the query, not to get individual patients, but to at least give you an idea how many patients might be eligible at different sites. And so for us, initially, we didn't have Bellevue or Grand Island as sites. Grand Island was initially just because of the distance, and Bellevue was one where they were kind of struggling with the early phases of COVID and didn't want to participate at that time. When we went back later and kind of ran the numbers, it turned out Bellevue and Grand Island were like the highest concentrations of potential folks to enroll in the study. And that kind of tipped our hand to, as COVID started to evolve, to then go back to them and say, hey, would you be interested in being a study site? And both of them agreed, down the road. And they've been a great place for us to get, additional patients for our study. And then the last thing is, as a PI, you certainly want to make sure you're avoiding bottlenecks. And often that's me, because there's the initial contacts, and then it's like somebody needs to review the chart to make sure that they're truly eligible, and I need to make sure that I'm dedicating appropriate time to make sure that I'm not blocking the process and holding up the entire team at that point. Similarly, since I have to call all the folks after they get consented, I need to make sure I prioritize making those calls so that they can move from being consented on paper to actually getting entered into our study database. So at this point, I'll sum up, and both Carol and I are happy to take any questions that folks might have. So really, I found that working with ProCoreNet has been a great way to get involved in clinical research, network with other researchers in my field. I've really enjoyed working with the ProCoreNet team, and I'm really thankful to them for initially inviting me to be involved in one of these studies, and then for all the help they've given me over the years. You do need to be mindful of the budget before you're committing to a study, so certainly review that pretty carefully. And then kind of the lessons learned, certainly make sure you're engaging with IRB and your clinical sites, kind of early on in this process, to help kind of set the stage to be successful. So at this point, I'll take any questions, and I'm sure I see Carol on as well, and she'd be happy to take questions. And I just wanted to thank the ProCoreNet team that I've been working with. So that's Sarah Kirk, who's my study coordinator, Annette Wolf, who works through ProCoreNet and does responsible for a vast majority of those initial contacts. I'm really thankful for all the help that Carol's given me over the years. And then to Jim Campbell and Jim McClay. Jim Campbell has really been a whiz at getting that computable phenotype to work within our EMR system. And then I'm really thankful to Jim McClay, who was the initial person that reached out and got me engaged in Preventable in the first place.
Yeah, thank you so much. That was fantastic. We had a question in chat, but I think you got to it. So does anyone else have any other questions?
So I see the question about the three patient contact or three contact rule. So basically, in the interest of avoiding coercion, there is a limit to the number of contacts, the number of times we can ask a patient to participate. Nationally, that has been around 7. So Vanderbilt and Duke, for example, go up to 7 contacts before they stop contacting a patient. We at UNMC are limited to 3, and that is any form of contact: email, mail, phone, in person. We can only touch them 3 times before we have to stop reaching out.
Thanks. Can you clarify sort of what the definition of a contact is? If anybody's, has tried this, and you have to arrange a phone call, you frequently can have multiple contacts before you can schedule the time, for an interview. Does each of those phone calls, trying to schedule, a visit or a lengthier phone call, does each of those count as a contact?
So my interpretation is not necessarily. So for example, if we reach out to the patient by email, and then we reach out by phone and they say, I didn't see that email, would you send it to another email? We don't necessarily count that as the total of the 3 contacts, in part because they didn't get the first one, and in part because they've invited further contact. So it's that invitation for further contact that that for me is that allows the interaction to continue. Now, the hard part is when I actually had someone not that long ago that it took about 5 contacts to actually get the interaction to happen. And I had made the note in my own head that this is the last contact before I consider the inability to complete the interaction to be actually a statement of not wanting the interaction. The IRB, in my view, isn't explicit on this, but in reaching back and asking a question early on, IRB actually confirmed for me that if there is an invitation to continue the discussion, the interaction, then you're stepping out of the 3 contact rule. Does that make sense?
Well, that's whether it makes sense or whether it's actionable is slightly separate. But I think it's an important definition that obviously the deal with IRB rules is that you have to follow them. I mean, if you want to grouse about them, you can do that, but you have to establish that at the level of policy. And 3 contacts, as you commented about, could often be, I mean, it sometimes takes more than 3 contacts to schedule a visit with the doctor when you want to do it. So with phone tag being what it is, it's potentially an issue, although the invitation definition may cover a lot of that.
Right. So if you leave a voicemail, that counts as a contact. If you send anything that you send that directly goes out, that you have sent and you don't have confirmation that it wasn't received, is considered a contact. However, per my discussions with IRB early on, if they invite continued interaction, that is separate from the 3 contacts. And if there's anybody on from IRB who would like to add to or clarify, please feel free.
Hi, Carol. Hey, I just wanted to introduce myself. I'm actually the new research recruitment and outreach coordinator. So I'm in the VCR office and I have been doing opt-in work for the last couple of months. So the 3 contact rule, how it works is a lot of times you go through us, and Deb and Max here in the office would be helping you. And we make a spreadsheet for you. We dole out the phone numbers or emails, and we handle that. And then every time you either send an email, make a phone call to them and leave a voicemail, or send a letter to them, that's a point of contact. Now, if we get an email back that says this letter or this email, like the mail demon, whatever it is, it'll say like, did not receive, this email doesn't exist. We can either take those out of our system, we can try again, so that would also count. But say somebody replies to your voicemail and say, hey, I'm interested, what do we do now? Then you're free to contact them as you like. Does that clarify that? Does that make sense? Hopefully that helped a little bit. I know it's like really complicated, but once you see like the Excel spreadsheets, once we start helping you, we make it really easy.
Well, and I think what you're talking about, Haley, it's important to distinguish. We are not using the opt-in list. So we are a separate infrastructure, and the opt-in list is an important infrastructure that helps a lot of researchers.
Okay,
but
that's great to clarify.
We are decidedly not using the opt-in list. We are using ethical access through clinicians to contact using using a different form of ethical access. But Haley's infrastructure is another very important infrastructure, and we do work together in sending out, because as I described earlier, the sending of invitations, emails, or MyChart messages to patients is managed very tightly and through Haley and her team.
Yeah, and I'm still new and learning all the different systems. So I'm really glad you clarified for that for me, but I believe it's all the same, like the contact list. So hopefully it just helped to like make it make a little bit more sense.
Thank you.
Yeah.
Any other questions before we wrap up? We're almost at the top of the hour. All right, great. Well, thank you both for the excellent talk. If you did want to check out the previous recording we did on Preventable, we had the PI, Dr. Alexander, actually present last year around this time. So if you wanted to learn a little bit more about the study, there's more on our website there. So thank you all.
Thanks, Jared.